Greetings, everyone. My name is Christina Baloescu. I'm a faculty member at Yale in emergency medicine, and today I will be discussing the project entitled Post-Admission Length of Stay in the Emergency Department is Associated with Increased Cost of Hospitalization. Emergency department boarding, which is the practice of holding patients in the emergency department after they have been admitted to the hospital due to unavailability of inpatient beds, is common and contributes to the public health crisis of ED crowding. This is a problem on everyone's minds, including the general public's, as evidenced by these high-profile pieces in the Wall Street Journal and NPR. The Institute of Medicine designated ED crowding as a growing national crisis. Robust data exists as to the effect of ED boarding and crowding on access and quality of care. Prolonged ED boarding adversely affects patient satisfaction among ED and hospitalized patients and negatively impacts provider attitudes and experience. ED crowding is linked to delays in definitive treatment for many conditions. Boarding is associated with greater odds of inpatient death for critically ill patients and those admitted to non-critical floor beds, longer hospital length of stays, and delays in definitive treatment. ED boarding impairs access to timely emergency care. Prior work has documented the clinical harms of ED boarding, resulting in limiting access to emergency and hospital care, as well as quality of care. However, there are limited studies that have examined the relationship between ED boarding and an equally important domain of the iron triangle of healthcare, the cost of care. In this study, we examined the relationship between ED boarding and ED characteristics and risk-adjusted hospitalization costs as measured by national publicly reported measures. We conducted a cross-sectional hospital-level analysis using merged national data from two 2018 Centers for Medicare and Medicaid Services Hospital Compare Program datasets. The Medicare hospital spending per patient dataset and the timely and effective care dataset. Hospital Compare is a consumer-oriented CMS website providing quality of care information for over 4,000 Medicare certified hospitals, and this data is publicly available. After merging both datasets, we included all acute care hospitals with complete data for all measures in the analysis. The ED crowding measures analyzed included median time from ED arrival to ED departure for admitted patients, ED boarding, which was defined as median admit decision time to ED departure time for admitted patients, so the time from bed request to when the patient leaves the ED. ED volume, which was reformatted to a categorical variable. The median time from ED arrival to ED departure for discharge patients, and the median time from door to diagnostic evaluation by a qualified medical professional, as well as the left without being seen rate. Stepwise regression techniques were utilized to identify the most parsimonious model. Multiple linear regression analysis was performed to examine the association between each ED crowding measure and the Medicare spending per beneficiary, which was our cost outcome. The Medicare spending per beneficiary reflects a price standardized and risk-adjusted measure of Medicare Part A and Part B payments for services provided to a beneficiary during a spending per beneficiary episode. This episode spans 3 days prior to admission to 30 days post-discharge. The MSPB variable in the analysis is a hospital's average price standardized and risk-adjusted spending for an episode of care, divided by the median MSPB amount across all hospitals, and yields a unique score. Scores above 1 represent more spending compared to the average spending pattern. For our results, the 2018 datasets included 4,740 unique hospitals operating within all 50 states and the District of Columbia. 61%, or 2,903 hospitals, had complete data for all selected measures and were included in the analysis. Table 1, which is seen on the slide, includes the descriptive statistics for the included hospitals. We can see that hospitals included in the analysis were distributed fairly evenly among the ED patient volume categories. Hospitals averaged about 288 minutes from ED arrival to ED departure time for admitted patients. And for ED boarding, Hospitals averaged about 114 minutes, so almost 2 hours. The figure to the right of the screen shows that ED boarding and Medicare spending per beneficiary were significantly correlated. The table on the left shows the regression results. Regression analyses adjusted for ED crowding measures demonstrated that a 1-minute increase in ED boarding resulted in a statistically significant increase in the Medicare spending per beneficiary score. Regarding ED patient volume, hospitals with medium, high, and very high ED patient volumes were associated with higher Medicare spending per beneficiary compared to hospitals with low volume. Interestingly, the door to diagnostic evaluation time was inversely correlated to Medicare spending per beneficiary. Measures of ED crowding, notably ED boarding and door to diagnostic evaluation times, were found to be associated with risk-adjusted measures of hospital spending in our model. Hospitals with less ED boarding seem to have lower costs of care. The mechanisms mediating this relationship are not fully known and should be further investigated. ED boarding may result in greater operational stress, requiring use of ED resources for a larger number of patients. Given that most ED resources are focused on stabilizing and disposition of new and more acutely ill patients, patients boarding in the ED may not receive the same level of timeliness of care they would in an inpatient setting. This may result in the delay of administration of some scheduled medications, performing non-emergent testing, or in receiving consultation services. These delays may result in subsequent clinical deterioration and in turn increase length of stay and perhaps costs of care. It is also possible that longer ED boarding times occur at hospitals that are less efficient with inpatient care, which in turn further exacerbates ED boarding. These inefficiencies may include inappropriate testing or treatment, fragmented evaluations, between inpatient teams, or insufficient access to post-discharge rehab and skilled nursing services. These have all been shown to be associated with length of stay and could be responsible for increased costs. No matter the mechanism, our findings, if corroborated by further study, have potential implications for healthcare administrators, who often perceive competing incentives between cost, quality, and access. Our work suggests that two of these domains, quality and cost, in the context of the ED setting may in fact be aligned from the perspective of the hospital and patients. And supporting endeavors to reduce ED boarding can improve both clinical and economic outcomes. In conclusion, we found a relationship between measures of ED crowding, including ED boarding, and risk-adjusted measures of hospital spending. More research is needed to elucidate the mediators of this relationship. Policymakers and administrators should consider the financial harms of ED boarding when devising strategies to improve hospital care access and patient flow. Thank you.